and um, uh, thank you organizers for giving us the opportunity. At the outset, on behalf of my co-investigators, it gives me immense pleasure to share with you all the results of our study conducted at dedicated COVID hospital, ENT manifestation of COVID-19 in a dedicated COVID hospital, an observational study. As we are all aware that COVID-19 pandemic has posed a global challenge to public health, and so far there has now been standard of care in view of inadequate evidence on existing medicines and their limitations. COVID-19 manifests with a wide clinical spectrum ranging from no symptoms to septic shock and multi-organ dysfunctions. Based on personal experience, while working in COVID isolation wards, it was observed that there is a variation in presentation of patients from certain ENT manifestations ranging from deafness, vertigo, loss of smell and taste, to voice change and difficulty in swallowing, apart from sore throat, fever, and dry cough. However, since it was not so far studied prospectively with concerted effort, the present study has been carried out. The behavior of SARS-CoV-2 in some patients is contrary to the observation in other patients. This prevents suspicion of disease clinically and delays diagnosis and isolation of patients infected with the virus and therefore makes it more difficult to deal with the disease. Therefore, knowing the full spectrum of all possible symptoms associated with the virus is a first and foremost important steps in identifying infected individuals. Hence, the study has been undertaken to study ENT manifestation of COVID-19 in a dedicated COVID hospital, with primary objective being to know the prevalence of all possible ENT manifestations and to develop comprehensive checklists pertaining to these ENT manifestations, with secondary objective being to study the natural history of the disease pertaining to ENT manifestations, to study the prognosis of the disease pertaining to ENT manifestation, to know the deficiency in the documentation of presenting complaints by comparing the data gathered through concerted effort versus acquired through routine documentation, and to compare the prognosis of the disease between those with ENT manifestations and non-ENT manifestations. Approximately 350 patients were screened for the eligibility criteria, out of which 308 patients were selected based on inclusion and exclusion criteria. The study was explained, informed consent form were served. Participants were evaluated prospectively by undertaking detailed history pertaining to ENT manifestations and then examined clinically from ENT perspective. Retrospectively, data was collected from the existing documentation used for enlisting all possible uh, manifestations, and follow-up observations were recorded on day 1, 3, 7, 14, and 28 days of enrollment. Outcomes were compared between ENT and non-ENT manifestations and their correlation with respect to age, gender, comorbidities, and stage of the illness. And comprehensive checklist was formulated. The results of our studies are: it was interesting to note that the majority of the patients in our cohort, upwards of 87%, were having some or the other ENT manifestations. That is, almost 269 patients on 308 patients were having some or the other ENT manifestation, while only 39 patients were having none of the ENT manifestation. And the order of prevalence of ENT manifestation was loss of taste, followed by loss of smell, voice change, sore throat, vertigo, difficulty in swallowing, and followed by difficulty in hearing. We have also studied the four different tests and their prevalence test with respect to test disturbance. And the prevalence of loss of taste to salt was highest, being 81.8%, followed by loss of taste to sweet, followed by loss of taste to sour, and then it was followed by loss of the taste to bitter taste. It was also interesting to note that among the patients with the taste disturbance, the taste for bitter and sweet remained unaltered, while other taste being altered, as we can see in this table. It was further interested to note that among the patients with a sore taste disturbance, the score has normalized, that the taste has normalized on day 3. However, the taste for sore has remained disturbed, that is, it remained altered. The score has worsened after day 3 and it remained disturbed even after symptomatic COVID recovery. It was also interested to note in our study that majority of the patients having ENT manifestations were having an occult ENT manifestation. That means the patients themselves had not come to the clinician with the symptoms, but on detailed inquiry, these symptoms were noticed. The order of frequency was loss of taste, followed by loss of smell, followed by voice change, followed by vertigo, followed by difficulty in swallowing, and the hearing disturbance. It was also interested to note in this study that there was an overlapping of symptoms were observed. The patients who were having loss of taste, among 253 patients, 174 patients were also having loss of smell. Similarly, there were patients having voice problem and swallowing difficulty. The symptoms were overlapping. Based on the results of our trial, we have formulated a color-coded checklist. Uh, it was also interesting to note that the, the severity of ENT manifestation were directly proportional to the COVID-19 severity. The severe was the COVID-19 severity. The severe, the more was the disturbance in the ENT manifestation, except for sore throat and vertigo. So, as to summarize, overall prevalence of ENT manifestations in COVID-19 in our cohort is very high, upwards of 87%, that is 269 on 308 patients, as per our study. And most of these patients are having occult ENT manifestations. That means upwards of 97% in our study of these patients were having occult ENT manifestation, wherein the patients themselves have not come with these chief complaints, but on detailed inquiry and examination, these manifestations have been detected. Greater COVID-19 severity, greater was an ENT manifestation, except for sore throat and vertigo. Hence, it is prudent to include these symptoms in routine history taking and examination screening in fewer clinic and at trial sites for early detection and appropriate COVID-directed treatment based on the results of our study. We have proposed a color-coded checklist to be incorporated at trial desks for COVID screening. This may aid in expanding the scope of our awareness about various possible symptomatology of COVID-19 in day-to-day clinical practice. So as to conclude, it is evident that based on the results of that study, that the loss of taste is specifically attributed to specific receptors pertaining to the four basic tests. It was observed, based on the results of the study, that the beta tests remain undisturbed even after other tests being affected. And this suggests that probably the virus must be affecting afferent pathway of test sensation, and the site could be at the test bud receptors. Mechanism of loss of smell could be due to affection of afferent pathway at olfactory epithelium. Presence of voice change could be associated with possible neurotropism, loss of resonance due to upper respiratory congestion, or could be due to lower respiratory reserve in moderate to severe cases. Besides, the difficulty in swallowing could be associated with possible neurotropism by the virus. Vertigo experienced by patients may be due to possible affection of vestibular function, as we all are aware that viral labyrinthitis is a well-documented entity. Based on the results of our study, majority of the patients complaining of hearing loss are having bilateral hearing loss, which could possibly be attributed to affection of respiratory epithelium by virus, leading to bilateral eustachian tube blockage or possible affection of end arterial system due to vascular coagulopathy associated with pathogenesis of SARS-CoV-2 virus. However, the exact mechanism of affection of these special senses by virus is yet to be known. There is further room for research in this area. Thank you. These are my references. Thank you.
Thank you very much for introducing me. My name is Dr. Nina Mitic and I came from Serbia. Just a few seconds to open my presentation. Can you see?
Yes, we can see, doctor.
Thank you very much. So we can start. Um, Hello, everyone. My name is Dr. Nina Mitic, and I came from Serbia. I'm working private dermatologist practice, and I'm plastic surgery resident. So I'm also work for a medical team of your research. Today, I would like to present you a clinical case presentation of solving hypertrophic and atrophic acne scars by using collagen, radiofrequency microneedling, and radiofrequency surgery knife. So, all of you know about a different style and different types of acne scars that there is a very innovative that we need every time innovative protocols to solve all these problems. Sometimes they are on a surface, but sometimes they are like ice peak and very deep acne scars. So today I would like to share you one of my patients that I combined three different procedure in order to achieve the best results. You will see that this is a patient with severe acne problems, but this is very young patient, 32 years old, and he is 85 kilos. So totally health without any chronic disease and no allergy. This is his photo before and after, and you see here inflammatory process of the skin. So I would like to share with you how I combined the therapy for him and what I did in this situation. In this case, first of all, I think it's very important to solve the acne problems, to use oral and local therapy in order to solve the acne problems and solve the inflammatory process of the skin if you want to do something for the scars. So after that, I include apply and apply injectable collagen. This is 100 pure percent collagen from my company where I'm working, and this is also radio frequency microneedling in the same procedure, in the same protocol. Sorry, and at the end, when we sold everything, we include also radio frequency surgery knife for hypertrophic scars. As I'm on a plastic surgery field, also I would like to do something innovative for my patients, and that's the reason I include at the end this surgery knife. You will see a short video at the end how I do it, and at first no one believed that everything will be good at the end, but that's the reason I prepared this case report for you. First of all, what we use for a paros therapy and local therapy, this is something like usual dermatology for medicine for acne scars, for acne, sorry. And first of all, I include the isotretinoin. It was around 40 milligrams, and I increased to 60 milligrams. That was the therapy for 6 months. And after that, during this period of first few months, I include local therapy also, and it was erythromycin lotion, 2% morning, evening, 2 times a day. We did also a lot of chemical peelings in this first day before we start with isotretinoin to prepare the skin with azelaic chemical peeling of 50% and salicylic 18% chemical peeling. This is one mixture in one chemical peeling. So we did it 3 times every 15 days. And of course, benzoyl peroxide 5% gel, one times in the evening on the inflammatory acne scars, inflammatory acne. So the protocol, the main protocol was to combine radiofrequency microneedling and injectable collagen. So first of all, I think that radio frequency is very innovative procedure now in the aesthetic market, and a lot of doctors doing this in the regular daily practice. So you know that it can happen to do some surface damage of the skin, and everything of this increase the process of neocollagenesis, and that's the reason I want to increase more this process of neocollagenesis, and I include injectable collagen after 2 weeks. So I combine these two procedure, radiofrequency, and after 2 weeks, injectable collagen. Then after 2 weeks again, radiofrequency, and 2 weeks after injectable collagen. This is procedure of this two combination 3 times. So, about isotretinoin, that you know that it inhibits sebaceous gland and function and keratinization. So, the drug has been observed to reduce sebaceous gland and production of the sebum. So we solved the acne problems, and we start with the protocol. Uh, this was the first picture after we solving the acne scars, acne problems, and we have here atrophic and hypertrophic scars. We don't have active skin inflammation, and we can start the process of our protocol: radiofrequency microneedling and injectable collagen. I like to use injectable collagen for the atrophic scars, and because what is acne scars? This is a loss of collagen in the tissue, and we try to make up this loss of collagen. So yeah, this is bigger. And the radio frequency microneedling is okay, cosmetic procedure, and it uses tiny needles and radio frequency waves to rejuvenate facial skin. So the treatment is form of controlled skin injury, and this damage stimulates, like I said before, this growth factor and increase the process of neocollagenesis. So when we do it, what we only expect to rejuvenate the skin and surface. So this is only a short video just to understand what I use. Um, there is a lot of different device in our aesthetic market, and we do it for whole face here in this situation. For example, after that, after 2 weeks, we inject injectable collagen, and that was 100 pure collagen injected. This collagen is extracted from equine horse tendons, and we inject directly in the cheek, in the tissue, and where is the um, a lot of acne scars, mostly atrophic, and we inject directly in the scars, and we try to make up a loss of collagen. So definitely that result of improving skin texture. Radio frequency microneedling is a surgery procedure is to remove all hypertrophic scars. Now you will see the short video about it. See how deep is this. And in this gap it was a lot of hair inside, and constant um, increased the inflammatory process. Before he came to us in our clinic, he had here abscess. So we try to remove these keloid scars, and never catch the health skin, only stay about the scars. So you will see now the photo. We remove all this scar. And now we're waiting to repair the tissue. This is before and after, and a few days after, and this is at the end. So one more time with the picture. Look at this gap here, and with a lot of hair inside, and this is immediately after the procedure. This is also before and after, immediately after the procedure. And like I said in my abstract, that at the end I put the PRP treatments just one time to finalize this protocol and to give the skin maximum of rejuvenation. So this was a few weeks, few days, sorry, after the surgical knife, and the right photo is 3 months after all procedure. So once again, how does it work? This combination of four different procedures are strong and powerful formula for skin rejuvenation, and they act synergistically to improve skin texture and remove acne scars. So final results is this. And to conclude that remove and solve inflammatory process of the skin before you apply radiofrequency and injectable collagen. Radiofrequency microneedling stimulates deep dermis to produce new collagen, and to increase neocollagenesis, injectable collagen was added in this protocol. So I think the final results are amazing. Thank you very much for your attention. I think I was precise and short. So thank you that I have this opportunity today to share with you my experience how to solve the acne problems scar. If you have any question, I'm here.
Thank you so much, doctor. That was wonderful.
Thank you very
Would
much.
anyone like to ask questions? If you do want to ask a question, just drop it in the chat box, or you can use your microphone. Okay, thank you so much, doctor.
Thank you.
Next, I'd like to welcome Dr. Alberto De Giuseppe from Padova University, Italy. Doctor, are you present? Dr. Alberto.
Good morning or good afternoon, everybody. I'm Professor Alberto Di Giuseppe. I am professor in Padova University in Italy, and I do practice in London as well in Harley Street. I did invent laser liposuction in year 2020 in order to improve the quality of the result in liposuction. The main idea is to utilize liposuction not only to remove fat, but also to sculpture the body. Thank you. Those are, oh, sorry, back please. Those are the books I published in aesthetic plastic surgery in my career, mainly with Springer editor. Body Contouring, Liposuction Principle and Practice, first and second volume, Tornado Corporal in Spanish, Stem Cell in Aesthetic Procedures, Cosmetic Surgery, Aesthetic Plastic Surgery at the Abdomen, Advanced Rhinoplastic, and finally the last book in Fat Transfer in Plastic Surgery. I devoted about 20 years of my career to work out and understand better which is the best philosophy and the best approach in order to contour the body. Initially, we were told that fat has to be removed. We learned by years that fat can be used to transfer and to fill the fat of the buttocks, of the body, of the breast, and then give a better shape. Next, please. The main article and the main advance in plastic surgery for ultrasound-assisted liposuction was made by an American researcher, Mr. Bill Cimino, who published in 2001 this article on aesthetic plastic surgery called Ultrasonic Energy, Power, Quantification, and Efficiency Optimization. Next, please. He did prepare and he did invent, with my collaboration for the clinical research, this device, which is the latest one on the market, which is called Vaser Lipo System. It contains a system for delivering ultrasound energy inside the body and emulsify the fat. Those fat cells can be utilized for fat transfer to follow. They are not destroyed. They're simply concentrated. They have atraumatic cannula for suction and minimize the trauma to the fat cell. They can improve the user interface, and they have a variety of probe for delivering ultrasound energy for a precise emulsification of the fat needed. Next, please. The main action is divided in 4 different steps. The first one is the infiltration of the tumescence in fluid solution, which is microbubbles, which helps to distend and decrease the consistency and stability of the fat cell. Next, please. The second phase is the emulsification. The ultrasound probe, which you see on the right side of the slides, is inserted into the tissue with a skin protector and helps fragilizing and emulsify the fat cell. The cavitation phenomenon is the result of the acoustic energy, which is delivered through an ultrasound probe, which make the fat cell, the adipocyte, explode. Once they explode, there will be a delivery of a sort of emulsification, a cream made by the fat cell explodes as well as the fluid which has been infiltrated first. Next, please. Finally, the aspiration. Aspiration has been to be done on the intermedium and linear level for decreasing the amount of fat and the thickness of the tissue area, but it also had to be done on the superficial level in order to make the tissue shrinking as much as possible. It's very important. You can utilize this fat cell also for fat transfer. So in this case, you need a canister for conserving the fat which has been removed. Next, please. Finally, this is the final process of skin retraction, which makes laser ultrasound liposuction different from any other kind of suction liposuction. The standard liposuction technique is the blind technique where the surgeon enters with a cannula, destroys the tissue, but cannot make any differentiation between fat tissue, nerves, connective tissue, vessel. In this way, you aspirate fat together with other important structures which are important for the support of the tissue and the vascularization of tissue. In other way, is a blind technique. Ultrasound-assisted liposuction, on the contrary, is a selective technique. You only emulsify the fat and you spare all the vertical fibers, the elastic fibers, the connective tissue, the microvessel, and the nerves. So less trauma to the tissue, more selectivity, and finally, more skin retraction. Because if you go and you do harvest a very thin superficial flap, you can obtain an ideal retraction with vertical and horizontal fibers together. Next, please. Next, please. Just to show which means tissue selectivity. This is how you will see, if you do a combination of abdominoplasty, the post-ultrasound treatment. This is the cream which has been created with a kind, gentle emulsification of the fat and the preservation of vessels and nerves. You see, it's just a creamy, melty tissue from the fat which has been emulsified inside. And post-aspiration, just to confirm what I told you, you can see the vertical fibers, the connective tissue, the elastic fibers which has been conserved and exposed. So there is no trauma, it's very conservative treatment, and the more you expose these elastic fibers, the more superficial contraction you can achieve. Next, please. This is the main difference from ultrasound-assisted liposuction, canister, and aspirate, which is on the right, and the aspirate on the left. A suction-assisted liposuction, the standard lipo, is much more traumatic and produces more blood. Laser is selective, is a gentle emulsification, and produce softer, less bloody aspiration tissue. So you can aspirate more on a single phase without creating problem to the hemoglobin and creating anemia. Next, please. There's been a lot of study which has been done for the fat viability study. This is one of the main ones published by Panetta, which means 80% of the fat which has been extracted after laser is viable. So you can use for re-infiltration for the kind of technique you want, in breast, in buttocks for projection, in calves, whatever you need, or also in face. Next, please. Autologous fat transfer means removing fat from areas where there is a collection of fat and preparing the fat with after the emulsification, and then maintain the viability of the fat with special canister, remove oil, remove triglycerides, and that get ready for utilization for body contouring. Can be done on the buttocks for shaping and contouring buttocks tissue, can be done for shaping men in more athletic vision as in high definition. Next, please. Let's say what one can do in body, in male and female. Next, please. This is how to use the Vaser, protecting the skin from friction injury with this small protector. Next, please. This is a male gynecomastia after treatment. After emulsification of the fat, after emulsification of the gland, in order to attain the best kind of skin retraction, the surgeon must be able to free all the tissue. The free the tissue, the undermining, the thinning of the tissue is a prerequisite for obtaining the highest skin retraction. Next, please. That is how you need to have a full undermined tissue, very thin, to get the best skin retraction. Next, please. When you have a thicker glandular tissue, you can use a different kind of probe. With an arrow, we can even address the more glandular tissue. Next, please. This is the kind of probe which is needed as an arrow, which is acting on the top as a scalpel. Next, please. Okay, this is the probe in action when I use in gynecomastia or whatever part of the body. Next, please. Those are some of the kind of results in gynecomastia. You see, despite this is a man with a droopy breast, this is the kind of retraction you can see immediately at the end of surgery with a tiny incision underneath. Okay, next, please. Next, please. Thank you. Okay, this is the result in the long term. You see the skin retraction and the nice kind of shape with no other kind of scars. Next, please. This is the tissue which was inside the breast tissue. You see this is poor male gland which is being removed together with the fluid and the emulsified tissue. Next, please. Those are some kind of results obtained with Vaser for the breast tissue, Vaser for the fat tissue, and a minor incision to remove the remaining breast tissue. Next, please. Post-op result. Next, please. The other projection. Next, please. This is another case with a nice kind of result, post-op. Nice, please. And this is the tissue which is being removed together with emulsification. Next. So you can see that you can obtain nice looking result with no scars and with emulsification and removal of the glandular tissue as well. Next, please. Next, please. And you see also the uploading of the tissue, which was droopy before and is retracting nicely with no need of extra scar. Next, please. You can combine, as most of the time happen in men, gynecomastia with body contouring. Male normally tend to have accumulation of fat in the abdominal area, on the flanks area. And you see also this man, which is about a 55 years old person, 1 month after surgery, shows a nice result, a good retraction. And you see also in the breast tissue, the skin has been retracting with no other kind of need for scars. Next, please. Next, please. So shape, contouring, and retraction goes together when you're able to shape a body with Vaser. Next, please. Sorry, next. This is another kind of back, please. That is another one. No, the next one. Okay. You missed one case anyway. This is a secondary surgery. You see this person has been already treated as well. You see there is a depression on the left side of the breast for an excess of tissue removal. I reoperate this person by removing, giving a better shape, nice skin retraction, and I did have some fat on the left side of the areola to compensate the missing tissue. Next, please. You see the result from oblique view. Next, please. And the lateral view. So shaping, moldering, sculpturing is very important in male and female. Next, please. This is another person with an older skin. You see, it's quite an important gynecomastia. You see the kind of skin retraction and the skin redraping and a nice, better kind of shape and sculpture after surgery. Next, please. Next, please. Next, please. And posterior flanks as well. Next, please. This is another, thank you. Another person. I performed basal lipo to gynecomastia and abdomen as well. You see, not the skin retraction of the lower panniculus, which didn't need any abdominoplasty. This patient possibly was going to be addressed for another surgery with an open surgery, which is not needed. Just with Vaser, you had skin retraction. Next, please. You see from the lateral side, the droopy tissue has been redraped, the scar has been redraped, it has a nice kind of contouring and no extra scar. Next, please. Next, please. Back flanks and back dorsal. Next, please. Leonardo da Vinci, in his drawing, he presented an ideal shape, an ideal version of the athletic abdominal edges. This is called high definition. Next, please. Next, yeah. This is the studies of the musculature of the back of the arm sculpture. Next, please. Just remember, Leonardo da Vinci was not even an anatomist, was just a researcher and a sculptor. Michelangelo Buonarroti as well, in the Galleria dell'Accademia show and presented the marble statues with all the ideal shape of the abdominal and serratus muscle. Next, please. So the anatomy in men is different from women. It shows they have interdigitation between the rectus muscle, the limit from the lateral oblique muscle, the vertical edges of the rectus abdomini. Next, please. And in men, it's possible to recreate this anatomical shape by creating depression in between the two edges of the rectus abdominal sheet, the linea alba, and the lateral oblique margin with the rectus vertex. And this is kind of shaping you can obtain by kindly operating and harvesting a nice kind of body sculpture. Next, please. This is another kind of result, pre and post with high definition. Next, please. That's another result of this athletic body, which I did drape and sculpture, also the biceps, the triceps, the deltoid of the patients. Next, please. Next, please. And this is the planning, the artificial muscle drape definition recreated in the pre and the post-op. All the area of the chest, the abdomen, the inguinal ligament has been recreated, could give a better anatomical and athletic view. Next, please. Next. 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 This is another kind of patient where he was missing a rectus abdominis muscle. So I did recreate the rectus abdominis muscle by placing fat transfer. We can see represented in the abdominal edges. Next, please. Next, please. Next, please. So you see, I show you example of cases where fat can be utilized not only for removal, but also for reposition the proper way where you need. Female body contouring. Next, please. This is another example of how vaser liposuction, if it's performed by a talented and experienced surgeon, can save a lot of scar. These patients show a droopy abdomen And the majority of the plastic surgeon will address this patient immediately to have a abdominoplasty. On the contrary, I show that you can achieve nice skin retraction without any external scar by simply utilize Vaser in the proper way on the superficial and deeper layer. You see the skin retraction? Next, please. Next. From the lateral view, next, please. And the lateral view. You see also the back rows is being corrected, operating superficial and deep on the lateral flanks. Next, please. Next. And you see the back rows, which is nearly resolved by operating on the lower back. This is another of the features which is typical of Vaser, the possibility of redraping this kind of horrible kind of rows, which tend to accumulate on the back dorsal and flex on the torso of women despite aging. Next. You see the results. Next. This is a more ordinary kind of patient with a fat excess. Is an easier kind of result with draping, reshaping, and giving a sort of nice of LS gentle curve between the axilla and the flanks to give a better kind of female contouring. Next. Oblique view, you see the skin retraction with no need of tummy tuck. Next, please. And the lateral view. Next, please. The posterior view. Next, please. You can use also a combination of fat removal plus fat transfer to better address the contour of the buttocks and give a better shape. Ideally, you should have a very kind of thin waistline and giving a sort of more roundness to the outer gluteus and to the main gluteus. Next, please. This is shaping and making a thinner waistline with Vaser. Next, please. Also, arms has been treated together with the upper torso and the lower flanks. Pre and post-op. Next, please. Also, older patient can obtain a gentle redraping. Look, this patient is 75. Look at the axillary fat accumulation. The fat which is placed on top of the bra line. Yes, you can go on. And the skin retraction just with Vaser is amazing. No extra skin scars. Simply redraping by superficial Vaser treatment. Next, please. Another patient, younger, with a typical extra fat on the top of the axilla, which most women aids because give a sort of sign of older appearance, what we call the axillary tails, before and after treatment. Next, please. Next. The inner arms. You see skin retraction in the skinner arms without any kind of need for a thigh or a arms lift. Only by superficial liposuction, you see the skin underneath the arms and beneath the axilla, how it's being trained. Next, please. The contouring of the flanks as well with the back rolls. And you see the new shape of the lumbricalis muscle, which are visible and make a more athletic waistline. Next, please. Before and after. Next. Next, please. Now let's talk about thighs. Thighs is another excellent indication for basal liposuction. You can perform basal liposuction circumferentially, changing the volume and obtaining a great skin retraction on the anterior, inner, and posterior thigh. This is a pre and post-op treatment. Next, please. Next. This is an oblique view. You see the posterior trochanter has been slimmed, the upper flank has been limbed, and also the inner upper thighs has been slimmed as well to give a better contouring, which is a kind of better figure and a better female view. Next, please. And this is from the back. You see treatment of the flanks, of the trochanter, and filling the medium area of the trochanter depression of the middle gluteal with fat transfer. This patient is a sort of sculpturing combination of a removal of fat from flanks and love angles, as being told, and placing fat on the middle gluteal depression to give a better roundness and improve the nice buttocks. Next, please. This is from the lateral view. You see circumferential time. Next view. Next. This is another case. Sorry. Earlier one, please. Perfect. Thank you. This is another case of shaping, reducing the waistline, reducing the upper part of the waistline, contouring the trochanter, and filling the lateral buttocks. Next, please. Next, please. And you see shaping and giving a better line, despite you see from the skin quality is not a young person. Next, please. This is what we call another BBL, which is a Brazilian buttock lift. In other way, is a way to lift your buttocks by placing fat. This patient had a contouring, a liposuction with vaser of the posterior trunk on the posterior lateral flanks, and then fat has been placed on the buttocks to increase projection and give more roundness. Next. And you see the better kind of shaping which has been obtained, which are more feminine, attractive kind of figures, respecting the L and S-shaped line. Next, please. Lateral view. Next, please. And this is from the front, the new kind of shaping, the better contouring, the nicer kind of view. Female body has a different kind of anatomy, so the plastic surgeon should respect the anatomy of a woman. Women don't have six packs, so you don't have to recreate six packs on a woman. Women want to have a thinner kind of waistline, but they want to conserve flanks. They're going to have a thinner kind of inner thighs. Next, please. You see this kind of shaping, removing the extra fat, but mainly giving a nice contour. Contour is an artistic kind of option. Plastic surgeon should be having an artistic view of the body in order to sculpture the best kind of ideal to attain a nice and proportional result. Next, please. This is another patient with the same kind of contouring. This is a very typical appearance. Buttocks lose volume and contouring. And there is an extra fat on the top of the torso and on the flanks. So ideally, you should contour, remove the extra fat from the lateral flanks, from the upper torso, and then feel the buttocks. Next, please. I see this is the patient from the oblique view. Next, please. And from the lateral view. You see better appearance, better shape, nicer kind of proportion. Next, please. And this is a patient that I'm particularly proud of because I want to show you she is a patient of 65 years of age. She had vaser liposuction on the posterior trunk, and you can see the skin retraction she obtained. She had no extra body procedures. She had no torsoplasty, no uplift. And I placed the fat into the buttocks to feel and uplift the buttocks. So this is the result of 2.5 hours of vaser body on the trunk and fat transfer to the buttocks. So you see how you can mold and obtain skin retraction without any kind of other aggressive surgery. Next, please. You see the contouring and you see the impressive retraction of the skin. Of course, she's not perfect, but look how she was before. She's 65 years. We know kind of torsoplasty, tummy tuck, etc. Next, please. This is another 58 years patient with a better kind of skin. She had the same, she had back flanks with no shape, she had buttocks with no shape, and they looked to be empty and droopy. I did BBL, fat transfer to the buttocks, and I did flanks, waistline thinning, and filling of the contouring of the buttocks as well. And this is the result. Next, please. You see the contouring. She had a tummy tuck before, and it was a very high line with the tattooing. And I went back to smooth all the contouring, make thinner, and give a better kind of shaping as well. Next, please. And here's the result from the oblique view. It's nice contouring, nice skin. Next, please. And the lateral view, you see mostly the lateral part of the skin with vessel undermining and redraping. The skin has been redraping. So this kind of laxity, loose skin has been taken care simply with vessel. There's been no renubium, no other kind of treatment apart from vessel. Next, please. Next. Okay, this is another contouring, upper, lower abdomen, flanks, inner thighs. Next, please. This is an easier case because it's a younger patient. You see, she wants to have a real nice contouring buttocks. So I use most of the fat for contouring the outer side of the buttocks. Next, please. And you see the kind of shaping and the plan where the fat has been removed. The waistline has been thinner, and the contouring of the outer buttocks with the nice kind of results. It is 3 months after surgery. Next, please. And you see the long-term posterior result. Next, please. Other case, similar kind of treatment, thinner waistline, get rid of the baker rolls, feel the buttocks, give shape, and get projection. Next, please. This is how to work the plan, where to place the buttocks fat and to thin the lateral flanks. Next, please. Bezier can be used also in arms, lower arms to get skin retraction. A lot of patients complain about fatness, but also looseness of the lower arms. And a lot of patients believe they need a lift or a skin incision. We want to show that you can get rid of this spot problem only with Bezier, achieving a nice kind of result with good skin retraction. Next, please. Before and after. Next, please. Next. There's another patient, before and after. Next. And you see the kind of shaping and the skin retraction we know need for any external scar and lift. Next. Also the kind of droopy skin, you see how you can achieve a nice kind of contouring, a skin retraction. Next, please. Next, please. Next, please. Next, please. So, technology combined with the talent plastic surgeon can obtain nice kind of body contouring result. New technology combined with an experienced plastic surgeon with an artistic view of the body contouring, using fat for removal and fat for adding and reshaping, can now obtain superior quality results and ideal kind of shape in body contouring. So this is the message I want to leave you regarding the utilization of ultrasound in experienced hands for aesthetic plastic surgery body contouring. Thank you very much for everybody for attending. Hope I've been in the time.
I'm Dr. Victoria Paez. I'm an aesthetic physician from Spain. And then I have here we are, sorry. I have about 30, I share my, okay, here we are. So I have about 30 years experience in aesthetic medicine, and I started working with can you hear me well? Is everything okay? Sorry?
Here, doctor.
Yes? It's okay? Can you see my screen? Yes? You tell me, please? You can hear me?
No, I'm just saying I can hear you, doctor. It's fine.
Okay, perfect. So in the year since 2020, 2009, I started working with polylactic acid. And then since that, I have a lot of experience treating the face and treating with body treatment, body procedure, not surgery, body procedures. I have no conflict of interest. Usually I'm training with Sinclair, but all my presentation is out of my experience with the polylactic acid. So what about collagen? We are talking about collagen. Collagen is on fashion. Since we are 30 years old, we start losing collagen production about 1% per year. So it's very important to maintain the collagen in the body, to treat the laxity of the skin, and to improve the shape of the body. So the collagen when you are young is mainly in the skin, collagen 1. Collagen 3 is also important, but the collagen fibers in a young skin is strong and act as an scaffold and maintain the structure of the skin. The collagen is 70% of the skin composition. Is also in the bones, 90% in tendons, in cartilages, in arteries, in lungs, etc. So in the young skin, the collagen maintain the structure of the skin, helps the skin to retain the elasticity, give a kind of scaffold for the hyaluronic acid, and it's very important to maintain the young of the skin, the elasticity of the skin, the quality of the skin. And with the aging, you lose the collagen, the fibers, they are not so strong, they cannot maintain the structure, and then you get the sagging of the skin. And then with the PLA, we can use to recuperate the collagen of the skin, but also we can use it to improve or to recuperate the volume of certain areas of the face and the body. How work the PLLA? The PLLA is a polymer. Is polylactic acid, is polymer made of monomers of lactic acid. Polymers were discovered in 1930. So the degradation of the PLA is accompanied with collagen production, and not only collagen production, also make the action in the fibroblastos and stimulate the proliferation of fibroblastos. So at the end, we will have more volume with these new cells, new fibroblastos that can produce more collagen. So we can establish different procedures to recuperate the collagen of the skin, to get the volume, to recuperate the volume that is lost with the aging. Even we can recuperate after a liposuction, of course not with this amazing doctor of the first presentation, because it was amazing result, but sometimes after the liposuction you can have some lack of tissue, and then can be even recuperate with this procedure that is not surgical, that can be made in a very out of the operating theater, in a very easy way in the office, and this is the way that collagen, that the PLA. Sorry that the video is in Spanish, but the fact is that when we insert the PLA in the skin, in the subcutaneous tissue, is able to get result of new collagen production, even to get into more than 2 years, results that last more than 2 years. And what about the toxicity of the PLA? The toxicity is 5, like we can see here, 5,000 milligrams per kilogram. So really we have a product that we can use over the whole body that is very safe, is already proved, and when we use in a consultant, not in an operating theater, the only limit we have for using that is the amount of lidocaine that we use in our procedure, because we cannot do the treatment, perform the treatment without any lidocaine, without any anesthesia. So what is used the PLA? The PLA is useful for any area of the body that shows sign of lack of collagen. Can be used for the back of the hands, or the inner side of the arms, of the inner surface of the thighs, to improve the gluteal region. Usually we will see later with the depression, supratrochanterial depression of the upper knee area, the abdomen through the periumbilical area, that sometimes we have sagging of the skin over there. In general, we will treat any laxity of the skin due to lack of collagen. These are all the areas that can be where the treatment can be performed. And then, sorry that I here some of the results we will explain later, because with the PLA is very versatile, so we can use to get more volume in a certain area, or we can use it to improve the quality of the skin, but without adding any volume to the treated area. The technique is important. Usually come in a kind of powder that have to be added with sterilized water, have to be prepared in a right way, because the PLA is not completely dissolved, make a kind of emulsion that we have to shake now and then to really get the product in a well prepared, and to achieve the best result. We have to organize a number of sessions, usually 2 or 3 sessions, depending if you want more volume or you want to improve the quality of the skin only without adding volume to the treating area. I use usually with cannula. After the treatment, is necessary kind of a massage to improve the result, because the PLA has this tendency to get nodules, and to avoid the nodules and to get better result is better after the treatment, and for a certain time after the procedure, the patient also have to follow. The follow-up is with some massage at home. The time between the treatments can be 1.5 months or can be 2 months, depending of the patient and depending what the result we want to achieve. For the gluteal area, of course, usually we treat this supratrochanterial depression, and we treat it not hyperdiluted with other areas, but very concentrated product, and we can achieve some good results, as I will show to you later. The technique is always linear retrograde technique, leaving some line of product and make a kind of cross-hatching where we want to get more projection. And for the inner part of the arms, also always we will make some vectors with the cannula and we will introduce the product in a linear retrograde technique. And also for the abdominal area and the inner part of the thighs, and very important, the playing of infiltration that have to be as deep as possible. That is very important with the technique. If we use the product with the IFU, then we have to be as deep as possible, always on the fascia, never intramuscular. And then if we use the product hyperdiluted, and then we can use it more superficial. And post-treatment, as I told you before, we need to massage the treated area. The first massage, I like to use it mupirocina, that is an antitopic antibiotic, because to maintain the more aseptic procedure. At the end, the patient during 1 or 2 weeks has to massage the area to avoid, of course, intense exercise, but it's a very light procedure. It's nothing that will keep the normal life of the patient out of refer to the procedure, and to avoid exposure to the sun, of course, especially in case of bruises that sometimes appear. We can combine treatments. I like to combine, of course, with laser sometimes, because laser work in another level, in more superficial level, and can improve the end result. With IFU or with radiofrequency, we can achieve very good treatments, very good results with this combination treatment when we are not doing a surgery procedure. And then this is one result. Of course, depend what you have previous. Your patient have a previous to the treatment, you can achieve better result or this result. With some vials, some procedures, we have 4 sessions, about 1.5 months between them, and we get improving. This is another view. And for the inner part of the arm, in a subdermal plane, a linear retrograde technique always. And I have many cases of this. We have a study that is finishing in a few months, and very good result. We're improving the quality of the skin. We don't treat the laxity of the muscles, of course. And this is for the abdominal area. In this case, I combine with the Morpheus, that is a fractional radiofrequency, and we combine the session of the PLLA with 3 weeks later, we have the radiofrequency fractional treatment, and then we combine several treatments of each one. And this is for the buttock area, and we can improve the volume of the buttock area, of course. It's another view. We can improve also some depression, improve in the buttock area. This is the tuberosity, ischiotic tuberosity. In this area sometimes appear a lack of fat that can be recuperated with the collagen that the acid, polylactic acid, is able to make. And this is to recuperate a depression, an atrophy of the area after many injections of insulin. So it can be recuperated, and you can achieve good results with a technique that is not very easy and to perform, and you don't have side effects if you know the product and you follow a good technique, of course. This is the upper knee, And then contraindication, of course. The contraindications, we have all these dysmorphic patients, or all these patients with pathologies, collagen-related pathologies, like different collagenosis, like the lupus erythematosus, as well as any collagen stimulator fillers, of course, if you have permanent fillers or allergy to any component, or bleeding disorder, of course, or any areas with active infection or inflammation, of course. So, in conclusion, we have a product that is an injectable filler we can use for the face and body, but is able to maintain results for more than 25 months. The results can be achieved even to 5 years, and is able to contour, reshape, and tighten the skin, activating the production of collagen, and we can have a very good result with a very simple procedure. Of course, have to be used by doctors with a specific training to avoid any complications. And thank you very much for your kind attention.
Okay, good morning, everybody. Today, I want to start my talk with a basic reflection, telling them that if the great war catastrophes had been prevented or predicted, detecting certain aspects that could have somehow diminished, attenuated, prevent an event from happening. So the story of the world would have been changed in an incredible way. Well, my dear colleagues, today what I want is to come and tell you that perioperative ultrasound is just that for you. I'm going to talk to you about many aspects of the use of ultrasound, but what I want to come and explain you, dear colleagues and friends, is that this is the time to incorporate, to introduce within the medical surgical arsenal that we have actually in our daily practice. So this is a tool that allow us to only perform a specific time of procedure, but also to make a diagnostic and therapeutic approach, using the ultrasound as an integral part of a perioperative in the before, during, and after the procedures. So my name is Dr. Luis Fernando Reyes. I'm a plastic surgeon, certified plastic surgeon from Bogota, Colombia, South America. I'm expert in perioperative ultrasound, and it's a pleasure to be here with all of you. So let's start with a little part of epidemiology. Why did the field of ultrasound come to mark such an important point in plastic surgery? So basically, this is an statistic from the ISAPS, International Society of Aesthetic Plastic Surgery, of 2021, in which there's a significant increase of the performance of one of the procedures that we do daily, such as the gluteal lipoinjection after the liposuction. So, since this has been carried out in the United States occasionally in the state of Florida in the last 5 years, there were 19 deaths from gluteal lipoinjection, and there were also 8 cases of embolic phenomena that occurred in a fatal process in the patient. So, for this reason, in this state of Florida, the regulatory authorities of the surgical medical practice of plastic surgery began to make joint task forces with the aim of trying to find some type of tool that could attenuate, decrease, or mitigate the side effects that occur during the procedure of gluteal lipoinjection. For this reason, and approximately in August of 2022, in the state of Florida, it is implemented the ultrasound as a part of the lipo injection, so the use of ultrasound during the procedure, with the aim of having a better visualization of the planes, a better visualization of the lipo injection cannula, and at the site where we are going to lipo inject or do the fat transfer. That's why this talk is born, and that's the goal, that we all begin to start, to identify several interesting things. Identify the muscle plane, identify where our fat plane is, where the peritoneum is. So if we manage to identify these structures, well, with the subsequent training, of course, we will develop the skills to be able to find where a cannula is, and at the same time identify the planes in an exact weight and at the time of performing a lipo injection. So there, all the time we hear that the ultrasound is very complex, that has many buttons, that it's a dependent operator, and it's difficult to perform, or only a radiologist can perform it. Well, there's some things that are true, but there are also some important things to highlight. The first one that you perform is that in the three pre, before, pre, intra, and postoperative areas, so before, during, and after the procedure, you will develop skills to be able to recognize all the tissues and get more all of the devices, the transductors, and their equipment in order to have everything clear. So, speaking about the ultrasound guide lipos injection, the first thing we have as surgeons, we need to understand that we need to identify the same planes that we already know from the anatomical point of view. So in that order of ideas, we are what we are going to do is a transfer the anatomy to a sonoanatomy transfer. So we need to be focused specific the area that we are working. For these reasons, it is important to know how to understand, practice, and train in this type of process under the ultrasound vision. But as I have been telling you in the talk, I don't only want you to stay with the concept of gluteal lipo injection. For example, in the abdominal wall, knowing the anatomy, starting from this principle, we can make ultrasound sweeps that help us to apply more safely procedures or process such as U-graft or muscle volumization in a specific muscle group. Other such as hernias or some abdominal wall defects that the patient had before performing the surgical procedure. Also, the correct identification of the muscle planes, understanding that from the top to the bottom, we have the skin, we have the subcutaneous cell tissue, we have the muscles, the external oblique muscle, we have the internal oblique muscle, we have the abdominal transverse muscle, which can also help them only not only for lipografts but also as an analgesic techniques that will help us as a part of a multimodal scheme in our patients. So that's why it's really important to have everything clear. So it's also important in breast the use of the ultrasound to achieve a better interpretation of the anatomical planes and ultrasoundly differentiate the glandular tissue in this area of our muscle plane. And at the same time, to be able to make a proper interpretation and evaluation of our silicone implants that we are all the time we place, and the implants that we take out at the same time. In this moment, we are in a moment that we take out a lot of implants with the explantation. So That's why it's really important to know exactly the ultrasound, the anatomy, and to be part of this word, this amazing word. So one of the uses that our plastic surgeons they ask a lot of in breast surgery is for the use of identify the different types of capsular contracture. How can I see a capsular contracture? How can I see the implant? Well, here it is. So we can see um, um, in this part we can see the capsular contracture, the lines, and we can identify this. So at the same time, we can use in facial surgery. So with our sonographic knowledge, we can have the anatomy and we're going to analyze and interpret it when we perform the ultrasound in the best way. For what purpose or what's the purpose of this? With the aim not only to identify basic structures like the lips, like dental structures, the orbicular muscle in here, like this image that you have in here. So dental structures like these ones, those are the lips, upper lip and lower lip. And at the same time, we can identify some vessels to avoid to get an injury when we do fillers or some type of another procedures in the face. So that's the idea to prevent and observe how complications are manifested. And there are many complications that we can evaluate with ultrasound. Today, as a part of the mouth opener of this talk, I just wanted to talk to you specifically some complications that we can have in all the field of cosmetic and reconstructive surgery. That is really important to know for you, dear friends and colleagues. So please remember, know the anatomy, and you need to transfer the anatomy to the sono anatomy. In that case, you will do the best for you, for your practice, and you will get a safer procedures. So in this photo, we can see a seroma, which is one of the most common complications in plastic and cosmetic surgery. But I can talk to you about an early detection of also of pneumothorax when we perform the taking of rib grafts and rhinoplasty. So we can do um, osteotomies for remodeling procedures for body modeling, so which are also fashionable. So you can use this tool like ultrasound to avoid or diagnose a complication. So I can leave you today a tip. We always ask to our anesthesiologist to perform positive pressure maneuvers with the aim of evaluating whether or not there are some leaks of air. Whenever we take grafts or we do the osteotomy as described, so we have a sensitivity and a specificity of this maneuver around 70%, 70, for pneumothorax detection. So, dear colleagues, with ultrasound we can have a 97% of sensitivity and specificity detection of pneumothorax. We have a protocol that is blue protocol, and we have the last one that is red protocol that we can teach you this. So for this reason and multiple reasons, UPlast Academy, which we are three plastic surgeons and one anesthesiologist, which we are experts in ultrasonography in plastic surgery. We are here to announce we are really happy and really proud to have this because it's really important for you to know that we have this for our patients, for our colleagues in this moment. We have this training in ultrasound academy, so you can train with us. You can have we want to talk to you about the use of ultrasound through the before, during, and after in every single procedure that we do, and learn to how to handle or have all the techniques that we allow you to know, and the maneuvers for your equipment, for you to know to maneuver your equipment properly. So that's what we're gonna do in here. We have 30% theoretical, 70% practical. So we're more than happy to invite you with our next courses in Miami in July, and we're gonna go to Barcelona, Spain on September, Dubai at the end of September, November. So we're more than happy to be here to announce what we are doing. We're improving our safety in all the procedures that we are doing in plastic surgery, and we're more than happy to show you this, to teach you how to do this in the best way. So another thing that I'm telling you is that ultrasound is not only going to help you within your clinical practice. Ultrasound has a basis in the legal part. So we're going to provide you all the tools for you to protect yourself during some adverse events that God wants doesn't happen, or some kind of complications. So this is the new tool for the doctor. This is an extension of our hands. We're ready to know clinically, and we already know, we want to know to show you how to manage it. This has been a pleasure. Thank you so much for your time.
Recording in progress.
Hello, chairpersons and all the colleagues. I'm Dr. Thi Ho Phương, come from Vietnam National Hospital of Dermatology and Venereology. Today, I'm very happy to present our topic here, characteristic of skin lesion in Vietnamese xeroderma pigmentosum patients. As the content of my presentation had three parts. First, overview of EP. Second, characteristic of skin lesion in Vietnamese EP patients. Third, genomic mutation in Vietnamese EP patients. About xeroderma pigmentosum, it is a disease caused by defective DNA repair, and it is an autosomal recessive disease characterized by some sensitivity, lesions of skin, eye, and nerve involvement, with high risk of malignant. SP is rare disease with the ratio is 1/100,000 in the world. The disease is caused by mutation in the gene encoding protein from SPA to XPE in the natural defense mechanism of the body called nucleotide excision mechanism that disrupt the DNA repair process. Mutation is equivalent to a group of the disease. In addition, the disease is also caused by a mutation in the 8th gene, HPV, located in the transcription synthase mechanism, which exists in the parallel with nucleotide excision repair in DNA repair. About clinical feature of SP include three main types. First, skin damage. Symptoms often appear on sunlight, exposed skin area. After a long time exposed to light, skin cancer may appear. Second, eye abnormality occur in 80 to 90%. Sunlight-induced ocular involvement such as photophobia, keratitis, atrophy of lids, cancer. Third, neurological abnormality are severe manifestation in approximately 25% of the patient, and one of the causes of death, the disease. Neurological manifestation can range from mild to severe. From 2008 to present, Vietnam has recorded about 40 patients diagnosed with EP. This is a genetic disease with a very small number of people. So currently, research on SP in the world and especially in Vietnam is still very limited. Therefore, research and identification of clinical feature mutation genes is very important to build diagnostic and management SP guidelines. So we conducted the research with two roles. First, describe the clinical characteristic of EP in Vietnam. And second, identify some genesis mutation of EP in Vietnam. We conducted a descriptive cross-sectional study on newly diagnosed EP patients in Vietnam from 2018 to 2023. These patients were diagnosed generally by medical history and clinical presentation. We collected 36 patients and took 15 of them for genetic analysis, along with 6 first-degree relatives. The following is result about characteristic of skin lesion in Vietnamese EP patient we obtained. We discovered 36 new SP cases during the study period. Patients lie mainly in the poor mountainous area in 11 northern provinces of Vietnam. Some province has more than 4 patients. The general characteristics of all SP patients are summarized in the table. The patient has mean age of 24 years, of which 64 patients were male. 22 over 36 patients had family members who were diagnosed with EPs. Age of the onset is similar to many other studies, about 1 to 2 years old, but the age of diagnosis is long, up to 68 years old. All cases present initially with cutaneous lesions, include sunburn with 41% and hyperpigmentation, like freckle or land disease with 58%. At the time of diagnosis, 15 over 36 patients had skin lesion in the both exposure and unexposure area. This is a picture of a 6-year-old boy with typical lesion of freckle in exposure area of the skin, such as a face and neck. The area under the chin is a carved area, so there is little damage. About sunburn, most of patient has symptoms of sunburn, about more than 97%. And common type of skin damage are land disease, dry skin, hyperpigmentation with a risk of more than 19%. The other lesions are also common are angiogenesis, seborrheic keratosis, and poikiloderma. Scars are also common, found in the area around the mouth. More than 50% of the patient in our study has scar in lip and nose. We also detected 24 cases of actinic keratosis. Actinic keratosis is more common in older people. 100% of people over 25 years old have actinic keratosis. And about skin cancer, we discovered 8 patients with skin cancer lesion. Among them, there were 6 cases of BCC and 2 cases of SCC. This is some picture of SP patient with skin cancer. The picture A and B show 2 female patients with multiple facial BCC, and picture C and D show facial BCC along with multiple freckle-like hyperpigmentation. The picture E show a patient with multiple freckle like hyperpigmentation and actinic keratosis in unexposed area, and picture F is a patient with post-BCC removal surgery on the face with multiple freckle like hyperpigmentation and atrophic scar due to sunburn. Particularly, the only case of death from skin cancer were a 16-year-old male patient. When we diagnosed, he had a giant tumor covering the entire face area, which biopsy result as low differentiated SCC. This lesion was diagnosed at the advanced stage and was no longer suitably indicated for surgery, and the patient also died not long after. Next, we move to part 3, genomic mutation in Vietnamese EP patient. We use next generalized sequencing technology to analyze gene for 15 patients and their family members. This table summarizes the phenotypic and genotypic results of 15 patients. General clinical characteristics of this group of patients are 100% patient with skin lesion, 80% patients have eyes involvement, and neurology problem occur in 50%. All patients carry variant in the EP gene. However, based on genetic analysis result, we discovered 3 patients XPA and 4 patients XPV, and other patients carry benign variants. Here we would report 3 cases in a cluster of case XPA with XP10 family. The patient XP10.1 onset at birth, patient XP10.2. She is a sister of XP10.1. Their parent died early, and patient XP10.3, cousin of XP10.1 and .2. He is the second child in the family. His parent and older brother are normal. Manifestation on skin are hyperphotosensitivity, hyper and hypopigmentation, dry skin, skin atrophy in the area exposed to sunlight, such as face, neck, back, or limb. Poikiloderma is also found on the face, neck, chest. They has conjunctivitis, photophobia, and dry eyes. In particular, the patient also have typical neurological symptoms with mental retardation, convulsion of limb, abnormal gene, and some seizures. And dermatology symptoms also appear similar to their sister. Patients also have eye symptoms. And 2 years ago, no neurological symptoms were detected, but 2 years later, the first sign began with abnormal gains, convulsion of limbs. There is the cousin of 2 patients above, from 4 months old. The patient began to have dry skin. Then other symptoms on skin appear like burning or hyperpigmentation on the face and neck. Eye examination also found the keratitis and conjunctivitis. 2 years ago, no neurological symptoms were detected, but now he can gradually become abnormal. Whole transcript sequencing shows the result that all 3 patients carry the XPAC.388 A to G gene variant in homozygous state. To further clarify the role of this variant in XP, we took blood samples from family members and sequenced the gene segment contain that variant. The parents of patient XP1 and XP10.1 and XP10.2 have both died, so we can only take blood from the parent of XP10.3. The results show that patient XP10.3 parents was both heterozygous with the variant C.388A2G. This is a general diagram of the XP10 family. Thus, the disease inheritance model in the XP10 family is consistent with the nature of an autosomal recessive genetic disease such as XP, inheriting two recessive genes from father and mother. Patient XP10.3 carry the homozygous gene of C.388A2G variant. Next, we would like to report the next cluster of 4 cases of XPV. This is family XP14, include father and daughter. The disease started at 2 years old. Daughter's symptoms were red skin when exposed to the sun, dry skin, hyperpigmentation on the face. There are no other skin lesions. Father's symptoms are diverse lesions appearing on the skin, on the face, neck, and arm, with sunburn, freckle, lenticine, dry skin, skin atrophy, and telangiectasia. And both of them carry the homozygous gene of the C.6H0G2A variant. And this is patient XPS.1. The disease onset at 10 years old with symptoms sunburn, especially in the summer, hyperpigmentation on the face, neck, dry skin, poikiloderma on the face, no damage to the eye and nerve. And he carried the homozygous gene of C.6H0G2A variant. And the patient XP16 had the first symptom on her cheek, seen like hood, lesion mainly on the face, freckle and hyperpigmentation. Other skin area and eye and nervous system have no damage. The whole transcriptome sequencing test for the patient show that the patient carried two variants, C.6H0G2A and C.1652C, and both of which are heterozygous. To further clarify the role of these two variants in the XP, we conducted a blood sample from patient XP 16.1. The result show that the patient father XP 16.2 contain a variant C.6H0G2A and not carry the C.1652C variant. So the patient XP 16.1 has inherited an allele from father with a newly arising mutation or inherited it from the mother. In general, the relationship between genotype and phenotype is very complex. And here I would like to summarize the lasting understanding of pathogenesis of this disease. The severity of XP disease depends on the mutated gene and type of mutated, along with environmental impact, including UV intensity, sunlight exposure time, tobacco, etc. To sum up, we have some messages about characteristics of skin lesion. Early age of onset, with the onset between 2 months to 2 years old, with hyper or hypopigmented lesion and dry skin are the most common. Basal cell carcinoma account for 16% with 6 people, and 2 male patients were diagnosed with squamous cell carcinoma. About genetic mutation, all 15 patients carry variant in XP gene. However, based on the genetic analysis result, we discovered 3 patients with XPA and 4 patients with XPV, and other patients carry benign variant. A family has 3 members with C.38 SA2G on XPA, and variant is genetic and cause skin and eye and nerve symptom. A patient has compound heterozygous genotype with 2 XPV variant RN C.6S0G2A inherited from the father, and C.1652WC suspected to be a newly arising variant or inherited from the mother. That is end of my presentation. Thank you for your attention. If you have any question or comment, please contact me at email address in the slide. Thank you very much.